The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. That was Sam and Dave, somebody who also was around before you were born, although the Blues Brother did also a really good version of it. And today, as you could see here, is April 7th. It's Thursday. It's 9 o'clock in the morning here in the Chicago Central Daylight Time. And this is our fourth webinar on central nervous system disorders, and specifically it's our 54th webinar of the year, of what's going to be probably like maybe around 62, 63, who knows. And today the topic is entirely only on one thing as our fourth CNS disorder webinar, brain tumors. And it's my favorite topic, you could probably tell. And also, I got another nice, pleasant surprise for you. It's going to be not long, okay? I know sometimes when I promise you it's going to be not long, we're here for hours and hours. And I'm going to promise you that this will be probably only about an hour, but who knows? If I get carried away and start telling you stories, it might be more. But it's not going to be a long webinar. And what else did I want to say? It's getting a little bit warmer here in Chicago. And how about if we get going? I don't think the one thing I did not show you yet during the opening song were my new stickers, which I buy from Dollar Tree. They're only $1 a sheet. And I just love to put them on my little outline sheets, which is right here. So as you can see, there's not very many little circles on this thing, so it's not going to be a long webinar, but that's okay. I don't feel guilty. We're going to have CNS5 next week in 5 days, and it's going to be a lab looking at brain disorders and spinal cord disorders under the microscope in virtual microscopy. And then in the 6th and final CNS, we're going to do the part of the central nervous system that people don't always recognize. It's the eye. And actually, I'm not going to do the eye, but my son is. He's a very, very famous retinal surgeon. And he's made a terrific movie, which we're going to watch. So I'm going to be cheating you that day. I'm not going to be flapping my mouth. We're actually going to be seeing my son on a movie that he made several years ago talk about the full spectrum of eye pathology. Okay, let's close off the ugly guy here and pop up the PowerPoint. And let's see what we could do here now. Here it is. Central nervous system tumors. Well, the primary central nervous system tumors are generally known as gliomas. That's because most of them are tumors of the glial cells, the various glial cells. Another feature of CNS tumors is even if they are malignant, they could be benign or malignant or low grade or high grade, they generally do not metastasize out of the brain or central nervous system. And you could probably Google a couple of cases in history where they did, but generally speaking, they don't metastasize. But gee, that's not really a great thing because even if they stay in one place, they could still be fatal, as you could imagine. So sometimes the word glioma is synonymous with the term astrocytoma. So most of the gliomas are gliomas or tumors of the astrocytes glia. Okay? Now, there are oligodendrogliomas, which are tumors of the oligodendrocytes. There are ependymomas, which are tumors of the ependymal cells. And you're probably thinking, well, are there microgliomas too? Generally speaking, no. However, the microglia, the macrophages of the central nervous system, very often are an integral part of some of these other gliomas, especially the high grade or grade 4 astrocytomas, which are known as glioblastoma multiformes. The glial cells in there, the microglial cells, can change the appearance and prognosis quite a bit. Now, do you remember when we said that glial cells are about 10 times more common than neurons? Yeah, you probably remember that. Maybe you knew it already. However, gliomas or tumors of the glial cells are probably also 10 times or more common than the so-called tumors of the neurons or neuron precursors, because a mature neuron, of course, cannot even multiply. It doesn't have a spindle apparatus. So all of the two major tumors of the neuron precursors, okay, are not nearly as common as the gliomas. And for all practical purposes, any primary tumor of the central nervous system, the neurosurgeons will probably just call a glioma. Okay. Now, do you remember that the brain also has a fibrous covering called the meninges dura mater? Well, you could have tumors or proliferations of these cells. They're generally benign, and as you would imagine, because they are fibroblastic in origin, they would be kind of firm and rubbery, like a super ball. And of course, could you have a primary lymphoma of the central nervous system? Well, are there normally lymphocytes in the brain? Yeah, maybe sometimes. Generally speaking, before the AIDS epidemic came around, nobody ever saw these. They were very, very rare. Now, when an HIV patient comes in with a primary, what looks like a primary brain tumor, it could very easily be a primary lymphoma, or it could be an inflammatory lesion called a toxoplasmoma, which is really not a tumor, but a lesion that is of toxoplasmosis. Of course, most of the malignant tumors of the central nervous system are metastatic. And specifically, as you could imagine, anything can metastasize to the brain, just like anything can metastasize to the bone, to the liver, to the lung. It's one of the favorite places. And in particular, when there is a metastatic lesion to the brain, more often than not, it's from a lung primary. Breast is pretty common too. Melanomas do it, but actually, anything can. That's logical. Okay, so what about the patient? Patient has a brain tumor. He usually has a very slow, gradual onset of symptoms, okay? It's not like a stroke where he might have them boom all of a sudden. If your differential diagnosis is between a stroke and a tumor, the main clinical feature is that the tumors appear very, very slowly and subtly. Most common symptom, well, you got something growing inside your head. It's taking up space. It's probably compressing the other things, including meninges. So headache, number one symptom. Vomiting, okay. Mental changes, well, that's not hard to understand because we're talking about a primary tumor of the brain. Motor problems too, okay. Generally speaking, not so much primary sensory problems, but motor problems. Of course, this can progress. These are generally a progression of symptoms. And of course, seizures would be a sign of fairly serious tumor involvement in the brain. And of course, increased intracranial pressure, which means possibly also increased pressure within the ventricles as well. Increased pressure when you do the lumbar puncture and see that the opening pressure is higher than it should be. Now, it also should not be surprising that a primary tumor of the brain, even if it's small, no matter where it is, it could be anywhere where glial cells and neurons are, okay, could present as a slowly appearing, localizing central nervous system abnormality. So take your brain, put your finger on any particular part where a tumor could occur, which is anywhere, and whatever symptom that produces could be the symptom of a primary or even metastatic central nervous system tumor. Well, let's work it up. You got a patient, you suspect it for any reason. Okay, of course, the first thing you're going to do is run out and get a CT or MRI, but let's do a history. Let's talk about how quickly this thing appeared, because you might be interested in differentiating this from maybe a stroke or CVA, which could appear very rapidly. You do a physical exam, a good neurologic exam, everything, a lumbar puncture, look at that opening pressure, send it to the lab for cytology. A malignant tumor could possibly have tumor cells within the cerebral spinal fluid. Okay, get a CT. You're probably more likely, as a knee-jerk reflex, to go for an MRI first, but they really complement each other. And another good thing to get, which you may get if the CT or MRI are abnormal, is brain angiogram, okay? A lesion which is very, very vascular, or let's say more vascular than the rest of the brain, could very easily be a tumor or even a malignant tumor, okay? And of course, biopsy, if needed. Now, as a pathologist, you very rarely have to go out in the middle of the night for a frozen section, but the times in my life that I've done it is when there has been a patient that's presented at the emergency room with perhaps some type of localizing CNS lesion, and they actually stick a needle into it. And sometimes you could tell instantly whether it's a malignant tumor, whether it's a benign tumor, whether it's some type of glioma, or whether it's a metastasis even, or whether it's nothing. Perhaps it's some other type of lesion in which there's a lot of glial cell reaction, and perhaps you may have a hard time differentiating gliosis from a low-grade glioma. Of course, if it's a high-grade glioma, there's a lot of necrosis, there's a lot of pleomorphism, there's a lot of palisading. That might be easy, okay? Now, so when you do your workup, whether it's CT, whether it's MRI, whether it's biopsy or a combination, angiography, these are some of the considerations in your diagnosis, because there's a wide variety of CNS tumor-like lesions. First of all, is it benign or malignant? Well, if you're looking at a biopsy and there's epithelial cells, like squamous cells or glandular cells, it's probably malignant, isn't it? Because think about it. Are there any normal epithelial structures in the brain? No. Now, you might say that maybe the ventricles, the ependymal cells look epithelial, but they're really not. You want to know if this is a primary lesion or metastatic? Now, even if it's only one lesion, it's just as likely to be metastatic as it is to be primary. Okay? Look at the location of the lesion. And does the location of the lesion explain the symptomatology of the patient? Look at the age of the patient. Many of the primary CNS tumors are in children. Okay, they're like leukemias. An old person could get a leukemia, but many of them are in kids. The same thing with CNS tumors. Not all of them, but most of them. But some CNS primary tumors are almost exclusively in children. Most of the other ones have a bimodal distribution where they might have a peak in early ages as a kid, and then they might also appear as an adult or even an elderly person. So if you do a CT, you want to know, is it dense? Is it more dense than the brain? Is it less dense? Or look at the MRI signals again. Take a look as to see whether there's a lot of water in it or not much at all. If there's a lot of water in it, it might be because it's necrotic in the center. And what kind of tumor would be necrotic in the center? Probably a malignant one, because it's growing so fast that it's outgrowing its blood supply. Are there calcifications in the tumor? Okay, some tumors, for example, like oligodendrogliomas, they can really calcify. Some of them don't at all. Okay, so you could have, let's say an example, a malignant oligodendroglioma might have just as dense calcification as the skull itself. On the other hand, it might be completely watery on the inside. Vascularity. Maybe you could tell from some type of angiogram you did, maybe a nuclear angiogram, maybe a vascular arteriography, okay? But wouldn't it be probably logical that the more vascular a tumor is, perhaps the quicker it's growing, and the more likely it is to be malignant? On the other hand, tumors like meningiomas, for example, they could be extremely vascular, but they're almost never malignant. Necrosis, okay. One of the main, perhaps the biggest differentiation between a low-grade glioma and a high-grade malignant glioma is necrosis. So if you see a glioma and it's necrotic, it's probably not low-grade, no matter what the cells look like, okay? So liquefaction is another factor. You know, things that are necrotic in the center are generally liquid. But if you remember when we talked about necrosis or liquefactive necrosis, where the brain tissue becomes watery, not just edematous, but watery, is a feature of almost any type of brain lesion in which there has been some type of injury. Strokes can be liquefied, okay? Inflammatory lesions, abscesses can be liquefied. Tumors can be necrotic and therefore limp. Almost every type of lesion of the brain is edematous, perhaps even possibly gliotic too. So you want to know if there's edema. And of course, if you're looking at that brain on the autopsy table, and you still don't know what it is, or if you still don't know if there's edema, you might want to put a blindfold over your eyes and take off your gloves, because edema on a cut section of a brain in an autopsy room is softer. It might be a subtle softness that your eyes do not appreciate. And I knew a very all the neuropathologists will very often take off their gloves and put on their blindfolds if they're suspecting an area of edema. Of course, they may have already known, because on the MRI, edema can be very, very, very easily sensed, even if it's mild edema. And of course, compression of neighbors. Okay, could it be compressing any part of the brain? Could it be compressing a ventricle? Could it be compressing or obstructing, the cerebral aqueduct? Compression of neighbors is important, and that might also help explain other features like the symptomatology. Now, you probably want to know what my biggest nightmare is, right? Of course you do. It's not the one I had last night, but it's the one I had all my life. It's called gliosis versus glioma. Gliosis, what we said, is a non-specific injury to the brain. Stroke, inflammation, tumor, degeneration even, okay, demyelination. Okay, it's like a collection of lymphocytes anywhere in the body. It's just very, very non-specific. But a glioma is also a collection of glial cells. Now, do you think a well-differentiated glioma could look identical to common gliosis? You bet it can. So that's why it's a nightmare, because if you get called out for a frozen section and you see a bunch of well-differentiated glial cells, you don't know if it's a glioma or gliosis. You might not know from CT, you might not know from MRI, you might not know from the biopsy, and guess what? You might not even know microscopically as well. How do you like that? So you look at the age of the lesion, the age of the patient. Is the gliosis in the white matter or gray matter? Is this associated with other white matter lesions like multiple sclerosis, or gray matter lesions like Alzheimer's, let's say? What's the texture of it? What's the vascularity of it? A collection of glial cells which is very, very highly vascular would be more likely glioma. A collection of glial cells which, for example, has a lot of mitotic cells would be glioma. But what if there is not much pleomorphism in the nuclei? What if there is not much darkening, which are the common signs of malignancy? You're still going to have a hard time. I put NC there because the cytologists like to talk about the nucleus cytoplasmic ratio. The higher that is, the more likely that those glial cells are tumor rather than nonspecific injury. What about calcifications? Well, that can go either way, I guess. What if the gliosis is associated with a cyst-like lesion? Well, does that mean it could be benign, or could it just be an area of liquefaction? Here's an interesting one. Satellitosis. What if your lesion, which is loaded with glial cells and perhaps not looking terribly malignant, has other little lesions around it, either on CT, MRI? Is that more likely to be glioma or gliosis? Well, it would probably lean towards glioma. And of course, what about delineation? Would a well-delineated area of glial cells be more likely benign or malignant? That could go either way also, So taking all of these things into consideration, particularly on the basis of the CT, the MRI, and the microscopy, you're going to decide, is this more likely a well-differentiated glioma in which you don't see many pleomorphic cells, necrosis, blah, blah, or is it simply a nonspecific injury to the brain? That's my nightmare. And I'm glad I don't have those anymore. Here you go. What are these? Well, they're glial cells. And you're probably thinking, well, how do you know they're not just lymphocytes? Well, there's a lot of stains you could do to show that these are glial in origin, okay? And you can see it's pretty well differentiated. you don't see much by way of big, dark, ugly cells. Maybe some of them are a little bigger and darker than others. So here, let me ask you the question. Is this gliosis, or is this part of a well-differentiated glioma? You know what? It doesn't matter what your answer is, because I really don't know myself. And if I saw this, I'd probably flip a coin or show it to a famous neuropathologist. I know a couple of them, and they probably flip a coin also. But take a look at these glial cells here. Do you see how big that one is? Do you see how big and dark that one is? You see most of the rest of them are pretty uniform in staining. Here's a big one too. Here's one that's a little bit bigger and darker and not quite totally round. So you would probably say this is more likely a glioma, but it doesn't look like it's a high-grade glioma. So, you know, you can grade these things on Roman numerals, like 1, 2, 3, or 4. 1 might look like, for example, normal glial cells, and 4 is obviously malignant. So this is probably about a 2, or what we call an intermediate grade glioma. But what about these glial cells here? Oh my God. First of all, they're big, they're dark, and do you see how some of them kind of line up like they're palisading? Remember we talked about cells lining up, sort of what we call palisading, like basal cell carcinomas or rheumatoid nodules, okay? You see also there's an area perhaps that you don't see much cellular detail. Maybe that's necrotic. Do you also see this blood vessel here? Do you also see how they're kind of growing more healthy around the blood vessel? Well, maybe this is malignant, and maybe it's so malignant that it's starting to outgrow its blood supply. So the most non-necrotic cells are near blood vessels. It's what they call perivascular tumor involvement. Whereas here, it looks like all of the cells may be dead. This is necrosis. This is perivascular growth, and this is palisading. Okay, what if I asked you to stand up and asked you to give me the 3 features of high-grade or malignant gliomas? You would say necrosis, palisading, and perhaps perivascular growth. Okay, and what's the most important? Probably the necrosis, okay? Because low-grade gliomas, I'm not going to call them benign. You'll never hear anybody say it's a benign glioma, okay? Even though some of them may not grow very much over many years. They'll never call them benign. But the low-grade gliomas do not become necrotic. The high-grade gliomas become necrotic because they're growing so fast they outgrow their blood supply. And overall, if you looked at the literature, you can see that somebody that's diagnosed with a high-grade glioma, or a glioblastoma multiforme is a better term for it, generally has a prognosis about like metastatic lung cancer. It's usually less than a year. I've seen it as low as 9-10 months. People with high-grade gliomas, if they're radiated chemotherapy, it's still a dismal prognosis. Here's another one. Could you appreciate the palisading better here? Could you appreciate this crumbly necrosis here? Could you appreciate this crumbly necrosis here? And to tell you the truth, I don't know what this is. This could be the middle of a blood vessel in which the wall perhaps is a necrotic. I don't know, but there's a collection of blood. That doesn't mean much, but palisading, necrosis, and we saw the perivascular growth. And look at some of these cells also just look as malignant as hell. Look at that ugly, irregular one. Look at that one. You know, this is a high-grade glioma in which palisading and necrosis, I hope, are well demonstrated. Here is an MRI. Do you remember when we were looking at the CT of brain lesions and we talked about the ring lesion? Well, that's a whole different thing, okay? This is a tumor. Looks like it's involving most of the temporal lobe, okay? And you can see it's brighter on the outside and darker on the inside. Now, that doesn't mean it's denser or has a capsule like we saw, for example, with the brain abscesses, but it does mean that it is perhaps more watery on the inside. And I know what you're thinking. You're thinking, well, wait a minute, didn't you tell us that the watery lesions are bright? Well, yeah, if you do a T2 weighted image, but on this T1 weighted images, the water can appear less dense than the surroundings. So this is a tumor, and it has what you might call a ring sign, but not the same type that you see in CT. It means that it's liquefied centrally. So if you were called in and you were asked and showed you this, a patient that came in to the emergency room, say, looks like he has a tumor in that temporal lobe. Well, is it benign or is it malignant? Well, it's watery on the inside. That means it's probably necrotic, which means it's probably malignant. If this patient had a lung cancer, you could say maybe it's a metastasis. If this patient had more than one lesion, you would almost certainly think it was a metastasis. But as you see right now, we got a tumor that is liquefied in the center in a patient. That could be a primary tumor, or it could be a metastasis. What are the chances? Overall, the literature says a solitary tumor, even large one, in the brain, is just as likely to be metastatic as it is primary, okay? So much for the gliomas, or what the might call a astrocytic gliomas. Now, is a glioma the same as an astrocytoma? Yes. But the neurosurgeons will probably call any primary brain tumor a glioma. But there are also glial cells, like oligodendrocytes, like ependymal cells, even microglia, which could be part of tumors or tumors of their cells of origin, and we would call them non-astrocytic gliomas. Remember this? This was a picture we saw in our last session. We said, those are slam dunk oligodendrocytes. They're in white matter. You don't see any neurons. You can see they're nice, round, uniform cells, and they all have this little halo around them because the halo is myelin. And if you remember, myelin is a fat, so it washes out when you do the routine stains. These are normal glial oligodendrocyte cells. What do you think this is? Well, they still have a halo, but they're not quite uniform and light. They still kind of look like oligodendrocytes, but this is an oligodendroglioma. And this is one of my favorite pictures right here, because the students, whenever you show them tumors, they say, well, how come you never showed us the normal to compare? Well, here's your normal oligodendrocytes, and here's your tumor of oligodendrocytes. Now, even though you see mostly oligodendrocytes, the tumor itself very, very often calcifies. You don't see any calcium here, but take a look at the CT. Look, this is a CT scan, and a tumor, at least the outside of it, perhaps the inside, is liquefied. But the calcification in this oligodendroglioma is almost just as dense as in the skull itself. Look at it compressing the ventricle, okay? The oligos, if you want to use the vernacular term, they're usually in the frontal or temporal lobes. They could be classified as high grade or low grade. Well, we haven't seen them microscopically, but what do you think it might be if it's liquefied in the center? It's probably more likely to be high grade, isn't it? And once again, this could be in adults, relatively young adults, especially men more than women, but it could also be in children. This is another tumor like the astrocytoma, that has both adult and children peak incidences. So we got one in men and women, particularly men in the relatively early 20s, 30s, but it also can be primarily in kids. It's only a couple percent of all brain tumors, but I think it's still the second most likely type of astrocytoma. And if you're a genetics guy, these often are associated with a 1 chromosome or small arm or a 19 chromosome long arm chromosomal losses. And of course, we already said this is probably the primary brain tumor that is most likely to calcify. Here I got another picture of a more subtle type of calcification, like here and here and here and here, and maybe even in there. See, this is CT again. Okay, let's move on to the next, glial cell. When we talked about glial cells a couple of webinars ago, we said that these glial cells, which line the ventricles and the aqueducts and the choroid plexus, these are ependymal cells. And even though they are glial cells, they look a lot like epithelial cells, don't they? They look like a little gland. And look at, they even have cilia. So now you know they are epithelioid in appearance and function. If you remember, their only job is to make water to circulate through the cerebrospinal fluid compartment. Okay? And I think I showed you this exact picture a couple days ago. Well, can I ask you a question? What if you had a primary brain tumor that looked kind of glandular, like maybe this? Say, well, wait a minute. You can't have a primary brain tumor in a brain. There's no epithelial cells. Well, there are ependymal cells which look and function like epithelial cells. So would you want to call this maybe a primary adenocarcinoma of the brain? You can't, because there are no primary adenocarcinomas of the brain. But you could call it an ependymoma, which looks very, very glandular and epithelial. So here you go. Normal ependymal cells lining a ventricle and ependymoma. Do you see the similarity? Okay, good. And here we go. Let's talk about the ependymomas, okay? They are from the ependyma, which you remember they're likely to occur where ependymal cells are, in the choroid plexus, which has gazillions of them, or even in the lining of the ventricles, okay? They could be slow or fast. They could behave in a more malignant, that should go without saying. And they usually are localized just to one area, and they're not common. This is only probably about 1% or less. I don't think I've ever seen more than about 1 or 2 in my life. And of course, if they grow in the ventricles, could they obstruct the ventricles and cause a hydrocephalus? A non-communicating hydrocephalus? Yes, they could. Okay? And once again, it's bimodal. You could get them in kids. You could get them in adults. And probably more, I don't know, I shouldn't say this because I'm not sure, but they're probably even more likely in a kid than in adults. Okay? But maybe I'm wrong. So the peak age incidence is at 5 and then at 34. It's only a couple percent, like the oligodendrogliomas. Okay? What is this? Now, wait a minute. Where have we seen this before? Do you remember when we talked about esthesioneuroblastoma? In the optic nerve? Do you remember when we talk about neuroblastomas in the adrenal medulla? And when we talk about pediatric diseases in a couple of weeks, we can talk about neuroblastomas in the abdomen is one of the more common primary malignancies of young children. Okay, so what is funny about this? No matter where these neuroblastomas are. This one happens to be in the brain. Wouldn't it be logical that a neuroblastoma would be in the brain if they're neural cells? And by the way, they are not derived from mature neurons. They're derived from neuron precursors. But do you see how here and 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 here? Do you see how these tumor cells often grow at the periphery of this neurofibrillary substance? It's almost like people sitting around the table, isn't it? These are called rosettes. So the point I want to make is 2 points. The first point I want to make is that if you have a tumor that shows rosettes, no matter where it's from, the optic nerve, the adrenal medulla, the brain, or perhaps in the abdomen, a big tumor in the abdomen of a little kid. This is classical for neuroblastomas. So almost all neuroblastomas I've seen have rosettes, no matter where they are. Okay, now the other point I wanted to make is, remember, I told you that almost all of the primary brain tumors are from glial cells, and that's what we saw so far. You know, the astrocytes, the oligos, the ependymal cells. But this brain tumor actually occurs from neuron precursors. That's why they're called neuroblastomas. So, of course, once again, it's not a mature neuron that it comes from, but it's from neuron precursors. So this is an exception to the rule. This is a primary brain tumor that is not from astrocytes, or not from oligos, or not from glial cells of any type. And guess what? Here's another one. This is CT. You can see a pretty dense tumor in the fourth ventricle, or the midline of the cerebellum, let's say. And the other ventricles look pretty good. And I'm going to zoom this thing here. I don't know why. But do you see, this is also a tumor from neurons, from neuron precursors. This is called a medullary blastoma. Now, can I tell you how you could look like a hero? I'll tell you how you can look like a hero. If you see a CT in a child, a young child, which has a tumor in the middle of the cerebellum, you probably have a histologically proven correct diagnosis of medulloblastoma. Here, let's make this simple. Medulloblastomas are neural malignancies in the midline of the cerebellum in young children. You know, of course, if there were like 20 other tumors everywhere else, you might think it's metastatic. But a primary tumor of the midline cerebellum in a kid is a medulloblastoma until proven otherwise. Any radiologist knows that as a knee-jerk reflex. And here's a coronal, or I'm sorry, a midline sagittal section of the brain where you got to slice right down the middle, median portion of the cerebellum. You can see the tumor. And that is a medulloblastoma. Okay, you know what? We're doing really pretty good. And we're more than halfway done. And I have really enjoyed myself so far, and it's not quite the full hour yet, but let's take our music break. I chose some really good things today. We'll come back and finish up, maybe only about 10 more slides, and hope to continue the fun in about 10 minutes.
saints turn into sinners. All the heroes and legends I knew as a child have fallen into idols of clay, and I feel this empty place inside. So I pray that I've lost my faith. Show me the way. Show me the way. Take me tonight to the river and wash my illusions away. Please show me the way. And as I slowly drift to sleep for a moment, dreams are sacred. I close my eyes and know there's peace in a world so filled with hatred, that I wake up each morning and turn on the news to find we've so far to go, and I keep on hoping for a sign. So babe, I just won't know. Show me the way. Show me the way. Bring me tonight to the mountain and take my confusion away, and show me the way. And if I see a light, should I believe? Tell me, how will I know?
Well, we're back. And I did put Rosa's picture on here during a large portion of our break. Rosa is my doctor. Okay, in case you wonder, who do doctors choose as their doctors? This is Rosa. She's my doctor. She's an MD. She was sort of my students once. I taught at a medical school that was pretty close to hers. And one day she asked me if I would go to her white coat ceremony. So I went there. And there were like a big ceremony there. There were like hundreds, maybe thousands of people. And, you know, the dean stood up and he gave a speech. And he said, I want to introduce two extremely important visitors to our white coat ceremony. And the first one was the president, the premier of the island. This was St. Kitts. Wow. And guess who the second one was? I just couldn't believe it. I practically fell over dead. It was me. So that's not why I like Rosa. And not just because she looks like a movie star or made me famous for 5 seconds. It's because she is a wonderful, spectacular woman who I have actually benefited from seeing for health advice. She is a nutrition-focused doctor. You know, she's not a whore for big pharma. She recommends vitamins for you that are parts of foods and not coming from the big pharma factories. Okay, I'm sorry. We won't talk about Rosa anymore. But what will we do? Well, we'll finish up. We only have like about 10 PowerPoints left, and I promised you that it would be not a long webinar, and look, it's not even an hour yet, and we're sort of like in the home stretch. So let's drop this down and turn off our music box and go back to the PowerPoints and talk about the type of brain tumor which is probably the most common, okay? But it's not exactly the brain substance itself. It's the meninges of the brain. If you remember the distribution of the meninges, and in particular the dura mater, which is the tentorium, the falx, basically these spindly fibrous-like cells which comprise the spindly fibrous dura mater are the origins of the meningioma. So where the dura is, meningiomas occur. That's why very, very often they're classically described as parasagittal. Why? Because that's where the falx is, okay? They are generally benign, but they can be locally compressive and invasive. Not what you would call malignantly invasive, but compressive. You know, I went to a conference once, I think it was in Cleveland Clinic or so, and there was an old surgeon there, a neurosurgeon. He got up and he goes, you know, those damn pathologists will always tell you the meningiomas are benign. But you know what? They can grow into your brain, they can grow into your skull, they can grow into your scalp, and if you let the damn things, they'll even grow into your hat. So yeah, they can be very, very compressive. And they're very firm. And they actually compress or displace the brain rather than microscopically invade it. You know, like perhaps a subdural hematoma might do it. And this is basically where they usually are. And because they are a fibrous-like tumor, they are very rubbery. They have the consistency of a super ball. And what most of them also have are little bodies called psammoma bodies. Now you remember we talked about adenocarcinomas like the thyroid papillary carcinoma or breast carcinoma, lung carcinoma, adenocarcinomas. A compressed, dried up, calcified papillary structure is often called a psammoma body. But these psammoma bodies are not epithelial or papillary in origin. They're basically little whorled cells, and they're very, very diagnostic. So here, what do I want to show you now? Here's a meningioma. Okay, here's the dura. Okay, do you think that this meningioma, which is pretty well defined, certainly doesn't have an invasive looking margin. Do you think that could compress the hell out of the brain? You betcha. Could it look like it could even grow into or near the bone, the skull? You betcha. So this was a particularly nasty one. And here we go, looking at a brain in which there is a good portion of this frontal lobe that has been compressed by this rubbery, dural-based tumor. Okay? Now, I gotta tell you a secret. I normally don't tell secrets, but I bet you almost every pathologist I know that have seen these meningiomas, we've seen hundreds of them, have probably thought, you know, this is so rubbery. It looks like a super ball. I bet you that a good number of those, and I'm not admitting it to myself, they probably bounce it on the floor to see if it bounces it. Now, I'm not going to admit that because I guess it's disrespectful, but that's one good test of seeing how rubbery it is. Look there's the dura, it's over the convexity. It's maybe not too far, of course, from the falx, but that's a classical gross meningioma. Microscopically, take a look at all these little circular structures. Some are calcified. Okay, these are your psammoma bodies. That one is really calcified. That one is a little bit calcified. But what they actually are these little meningothelial cells that often arrange themselves in a little specific whorled pattern. And these are psammoma bodies. And remember, they are not the same type of psammoma bodies that we saw with papillary carcinoma, the thyroid, or just about any other type of papillary adenocarcinoma. This is not epithelial. This is connective tissue. These are ultimately fibroblastic-like cells from the dura. Okay, let's talk about another type of brain tumor that's not from the neurons, and it's not from the glial cells. AIDS patients, HIV patients, frequently present with primary space-occupying lesions of the brain. Okay? And this is an AIDS patient. And you say, whoa, he must have some kind of tumor. Well, actually, it's not really what you call a tumor, but it's behaving like a tumor. This is toxoplasmosis. Now, the patients that have AIDS do have tumors, though, primary tumors of the brain at much increased rates, and they're lymphomas, malignant lymphomas of the brain, okay? So, before HIV came around, malignant lymphomas, primary of the brain, were unheard of. But AIDS patients get mostly B-cell lymphomas in general, and they can be primary in the brain as well. So here's the point I want to take home with you. If you have an AIDS patient and they come in with looks like a primary brain tumor, if it is a primary brain tumor, it's a very, very good possibility of being a primary lymphoma. But on the other hand, it could also be a localized lesion of toxoplasmosis as well. So that's the differential diagnosis of what look like primary brain tumors in AIDS patients, toxoplasmoma versus malignant lymphoma. Okay, you know, we've been ignoring the most obvious tumors of the brain, which are much, much, much more common than the primary tumors, and these are the metastatic tumors. You know, like we said at the beginning, any tumor can metastasize to the brain. However, by far, the one that's probably more common than all the rest of them are lung tumors. Could breast do it? Sure, they frequently do. Prostate, melanoma, common tumors, kidneys, GI tumors. Yeah, but without a doubt, lung is number one. So, you got a patient that comes in, I suspect him for some type of tumor. He perhaps has multiple lesions of the brain. You're suspecting a MET. You got to look at lung as number one, but it could be anything. Now, here's another fact that you should really understand. Patient comes in And we go through the whole rigmarole of a history, physical workup, biopsy, CT, blah, blah, blah. And he has a single, what looks like tumor of the lung. I'm sorry, of the brain. Statistically, it's just as likely to be a metastasis from another site than a primary brain central nervous system neoplasm. Okay, so keep that in mind also. We talked about paraneoplastic syndromes at length when we talked about malignancies in general. And of course, what about a tumor that involves the brain that comes from the lung, the so-called small cell or neuroendocrine tumor? If you remember the neuroendocrine tumors, the malignancies, the small cells, they can have a wide variety of hormone-like releases, okay? You know, not just cortisol, but a whole bunch of other things. So a paraneoplastic syndrome is a syndrome, patient presentations that come in with various type of problems. For example, a Purkinje cell degeneration. Remember, Purkinje cells are in the cerebellum. So if the cerebellum has a lot of Purkinje cell degeneration, these are the most branched out big cells of your entire brain, you have to suspect an underlying malignancy, even though the Purkinje cell degeneration is not in itself a malignancy. Patients with encephalitis, okay, or perhaps emotional type problems because of damage to their limbic system that appear. That could be a sign of underlying malignancy as well. What about a patient that has some sensory problems because of sensory neuron degeneration? And specifically, that would most likely be the dorsal root ganglion, remember? Or eye movement disorders. So you have all these patients that come in with these various symptoms, and it could be indicative of an underlying malignancy. We put small cell at the top of the list, but also lymphomas and also breast carcinomas. And if you remember, the lymphomas and breast carcinomas were part of the metastatic thing. Okay, how about if we go down to our last discussion, which is not going to be in great detail, okay, but we'll talk about brain tumors now that are genetic, they're familial, they're usually autosomal recessive, they can be in kids, okay? And when we talked about genetic diseases, we talked about neurofibromatosis. It is complex genetics, okay? But we said that in neurofibromatosis 1, you get these little bumps on your skin, classically look like neurofibromas. They also have pigmented spots because the tumor expresses melanin-like cells as well from the neural crest. But they can also have gliomas. So in neurofibromatosis 1, familial tumor, you can have gliomas anywhere where you could get gliomas. Now, we divided that also into another variant called neurofibromatosis 2. And they can get schwannomas, which you remember are tumors of peripheral nerves, basically, of the Schwann cells. But those do not have to be visible or palpable. They can be internal as well. But neurofibromatosis 2 is also associated with meningiomas. Now, here's the thing we're going to call tumor, but it's not really a true neoplasm. They don't call it tumor, they call it tuber. So tuberous sclerosis is also a genetic familial disease in which you have tumors or tumor-like overgrowths of tissue called hamartomas present. It could appear early in life. It could, of course, get worse. And it's something I personally have never seen. But remember, tuberous sclerosis can behave like central nervous system tumors. But you can also get them in other areas besides the brain. Now, In another familial tumor syndrome thing, we have a disease called von Hippel-Lindau. I didn't look at I didn't Google what these guys were or what they look like. But in von Hippel-Lindau, you get hemangioblastomas. And they're usually, most likely, chiefly in the cerebellum. So let's look at an MRI over here. And look, we got a big cystic-like lesion. We got a lesion here. We got a lesion here. So we have maybe looked at this with surgery or biopsy. And look at all of these blood vessels filled with blood. So these are the hemangioblastomas, which is a type of vascular tumor. And guess what? We're finished. And I told you it wasn't going to be long. I didn't lie to you this time. It's only like about 7 minutes after 10. So this was not a long webinar. And our next webinar next week, it's also, I don't think it's going to be long. We're going to look at the virtual microscope for various brain lesions. There's about 30 slides. Maybe I'll show like 10 or 15 or something like that. But that's our next webinar. And I think there was one more thing I wanted to say. Oh yeah, I remember what that was now. Besides, thank you, Rosa. I hope that you enjoyed this webinar. But I also want to say that the very last song that I'm going to play today, whoops, my hair is messy as usual, is, in my opinion, the most beautiful and spiritually uplifting song that I ever heard in my life. And it was given to us by one of the most famous concert pianists in the world, whose name is Yulia Lipmanovich, who, if anybody in the world has a taste for beautiful music, it would be this very famous person. Yeah, I do know a couple of famous people, okay? So let's close off our webinar today. What is, in my opinion, the most beautiful spiritual song I have ever heard. It's by a very, very famous and young opera singer with the most beautiful voice by the name of Charlotte Church, appropriately named.
Lead me
Rock on, buzzards.